So we're very pleased to welcome Helen today, Helen Ball, Professor Helen Ball, to give you your full title. Would you please remind us of the role that you currently do and your background?
Yep. Okay, I'm Professor of Anthropology at Durham University, and part of my role in that capacity is I'm Director of the Durham Infancy and Sleep Centre. So I run our research programme and also our outreach programme, which is called BASIS, the Baby's Sleep Information Source.
And we are certainly directing people as part of this course to many of those resources. Please, could you tell us a little about the triple threat model of SIDS that is mentioned in much of the resources on the BASIS site?
Yeah, so the triple risk model was proposed by Filiano and Kinney, I think in about 1994, and it's been used by SIDS researchers ever since to conceptualize how intrinsic risk factors and extrinsic factors and a critical developmental period sort of intersect to increase a baby's vulnerability on a particular night. So the three components of it are that the baby has to, for a baby to die suddenly and for no explained reason, which is what SIDS is, a baby has to first of all have an intrinsic vulnerability. So that might mean that it's born with some kind of brainstem anomaly. It might mean that it was born prematurely, which increases the risk. It might mean that it was exposed to smoke in utero, which increases the risk. So it's something that the baby that cannot be modified or ameliorated once the baby's been born. So some of the things that are intrinsic risks we can identify. For instance, if the baby was smoke exposed, we know that that's an intrinsically vulnerable baby. Other things such as genetic predispositions or brainstem anomalies, we obviously can't identify. So one of the reasons for giving all parents SIDS risk advice is because you don't know whether their baby is one that's intrinsically vulnerable. Then what seems to happen is that intrinsically vulnerable baby has to be exposed to a risk, an external stressor, and these external stresses are the things that we warn parents about in infant sleep environments. So, for instance, head covering, prone sleep position, etc., etc. But it seems as though, and this is the intersection of the triple risks, is that only has to happen on a particular night in a developmental window. And the developmental window is somewhere, for most babies, it's between 2 to 4 months. For premature babies, it might extend beyond that because of their developmental immaturity. So it sort of helps to explain to parents why they may have put their baby prone every night of its life, but it wasn't until it reached, 2 to 3 months that was those factors coalesced into a challenge that the baby couldn't recover from. Or it might be why they've had 5 babies and they've always, slept them with hats on or something, and none of the other babies have had a problem with that, but one particular baby did. So the epidemiology sort of identifies the external stressors. It identifies who are the vulnerable babies, and it identifies that the deaths tend to happen during this very clearly defined window. And the way that researchers then have kind of fitted all of that together is with this triple risk model, which looks like a Venn diagram of those three things coalescing, and the SIDS babies are the ones that happen to fall in the middle on any specific night. Does that make sense?
Absolutely. We talk about this risk with every parent, but can we just contextualize? I think it's also important to contextualize for parents how many babies do die of SIDS each year in the UK, because it is still a very small number, thankfully.
In the UK at the moment, it's 1 in 3,300, so we're averaging about 200 babies a year in England and Wales, about another 40 in Scotland. So, in the context of 700,000 babies or 650,000 babies being born in the UK every year, that's a very small proportion. Of the 1 in 3,300, the vast majority of those are in what we call high-risk groups. So they're babies who are born to parents who smoke or smoke during pregnancy. They're premature or low birth weight babies. They're babies who have slept with a parent on a sofa or with a parent who's been exposed to drugs and alcohol, etc. So there's a very, for low risk families, as in breastfeeding families who always put their babies to sleep on their backs, etc., and follow the guidance, the risk of SIDS is much lower than 1 in 3,300. It's that the 1 in 3,300 is an average across the whole population.
Thank you. And there's been some guidance come out in the last year or so from the Lullaby Trust around safer bed sharing, which is something that's quite new in terms of health professionals promoting bed sharing as a positive choice for parents. Could you tell us a little bit more about why we've been able to give that advice out now, whereas perhaps in the past health professionals have said bed sharing is fundamentally a no?
So the guidance has changed since NICE, the National Institute for Health and Care Excellence, re-examined the SIDS study data in 2014 and came to the conclusion that there was no absolutely firm evidence that bed sharing causes SIDS, that SIDS with bed sharing was associated specifically with smoking, with high risk scenarios. So that changed the conversation really around bed sharing and SIDS in the UK. And the Lullaby Trust, UNICEF, Public Health England and we got together to create that new guidance to provide that information to parents who choose to bed share, because we know that a large proportion, at least half of the families in the UK have their baby in bed with them at some point in those first few months. We felt that those parents needed information about how to do it safely and what does make it dangerous, that it's more important to warn people about the scenarios where it might be problematic than it is to tell people never to do it, because regardless of whether we tell people never to do it, they do it anyway. We all do it. So that guidance was about the best evidence that we have at the moment around how to bed share as safely as possible and what things to avoid.
One of the things that's changed in the market over the last few years is the preponderance of baby nests and baby cocoons that have come onto the market. And it's something that many parents choose to use. What's your view on the safety of these with infants?
Okay, so there's 2 points to make about those. One is that they're too new to have appeared in any of the epidemiological studies yet. There hasn't been a big case control study done since those kind of products came on the market. So we don't have any data about whether babies are disproportionately susceptible to SIDS in them compared to, any other sleep environment. But some of the concerns that have been raised, the second part, is that the guidance has always been that the safest place for a baby to sleep is in a clear, flat space. And a cocoon doesn't provide a clear, flat space. It's got borders around it, which might potentially be suffocation hazards if babies get their faces pressed against them, or they might potentially be overheating hazards if they completely kind of enclose the baby's head and it can't lose heat through its head. So people have got concerns around those kinds of nests and cocoons. One of the things that I think is most problematic is that they aren't intended to be used inside of cots, yet a lot of parents put them inside of cots. And one of the things that we've had discussions with parents about in various interviews and focus groups is what the benefit of using them is, why they're choosing to use them. And the argument tends to go that it's a nice, soft, comfy sleep environment, and therefore they feel their baby sleeps better in it. And this raises an important issue about the depth and duration of infant sleep in that particularly critical 2 to 4 month time period, because one of the things that does come out of the epidemiological evidence is that scenarios that cause babies to sleep more deeply than they normally would are actually the ones that are the most risky. So for instance, prone sleep causes babies to sleep more deeply. Overheating causes babies to sleep more deeply. So there's a reduced arousability when babies sleep deeply and for prolonged periods, and that seems to be problematic. It's associated with the higher risk sleep environments. So that's one of the things that all needs to be unpicked with regards to sleep nests, etc. But it's just really to urge parents to have some caution around the use of those products, and make sure that their babies are being observed while they're using them, really. if they choose to use them.
Which brings us very nicely on to what is normal for baby sleep from 0 to 3 months. And many maternity nurses will have worked for many years in environments where they are putting in routines for babies based around a 4-hourly or even 3-hourly feed sleep cycle. But of course, the research has moved on in terms of what we know about what's normal for baby sleep in those first few months. Could you tell us a little bit about what maternity nurses should be preparing parents to expect as a physiological norm?
Yep, so I think helping parents think about what is normal before they have their babies really helpful, because parents get bombarded with lots of cultural expectations from other people about, you know, getting babies to sleep through the night as early as possible, etc. But we know that human newborns are a kind of mammal who expect to be fed frequently during the night, whose babies are roused frequently during the night, who don't have a day-night rhythm. And so for the first several months, you know, parents should be expecting that their babies will be waking them up 2 to 3 hours every night. And that is normal, and it's something that they need to work out how their family's going to cope with, especially if they're breastfeeding. Mums need to breastfeed every 2 to 3 hours to maintain their milk supply. So you know, it's an important thing to do for both mums and babies, is to accept that regular night waking and work with it rather than trying somehow to suppress it or prevent it.
And so how can parents and their maternity nurses make sleep a safe environment?
So be aware of the safer sleep guidance. Make sure the baby is sleeping in a clear, flat space. If they choose to have the baby in bed, ensure that they are not in any of those high-risk categories, for instance, having smoked. Never sleep with their baby on a sofa. If they're going to bring the baby into bed, make sure there's space around the baby, the covers are away from the baby, and that the mom is sleeping in that curled up position, you know, so she's responsive to and aware of the baby during sleep.
Thank you very much indeed for your time today, Helen.
You're very welcome.